Good morning, sawadika. Good afternoon, ladies and gentlemen. So thanks to join 2022 Quitline in Smoking Session for Youth Online International Conference. I'm Nina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. So I'm also the moderator of today's conference. First of all, I would like to thank all of our online participants from different organizations and different sectors. Special thanks for our 5 speakers. I think the problem of youth smoking is a global concerning issue. So it will significantly impact the youth health even till they are aged. So many of countries set up national quitlines to help youth to stop smoking. So today we invite speakers from Switzerland, Thailand, Hong Kong, and Taiwan to share the experience of policy advocacy and the activity organized by the national quitlines to help youth with smoking cessation effectively. So before we start today's conference, I would like to invite Dr. Wei Xilun, the Deputy Director General of Health Promotion Administration, Ministry of Health and Welfare of Taiwan, to give opening remarks. Dr. Wei, please.
Thank you. Good afternoon, good morning, distinguished.
Could you speak louder?
Ladies and gentlemen, first of all, it's my pleasure to welcome you all to the 2022 Quitline in Smoking Cessation for Youth Online International Conference. As we know, preventing youth from smoking is important. The earlier we intervene in the development of tobacco addiction, the better we can alleviate its harm to the younger generation. According to the results of the 2021 Youth Smoking Behavior Survey in Taiwan, the smoking rate of middle school students dropped from 7.8% to 2.2%. The smoking rate of high school students dropped from 14.8% to 7.2%. However, the e-cigarette use rate of middle school students and high school students has increased from 1.9% to 3.9% and 3.4% to 8.8%. And the dual use rate of youth has increased from 2.7% to 6.6%. The use of novel and emerging tobacco products among youth has become an alarming issue. Quitline provides a portal through which smokers can seek assistance to quit and are a vital component of tobacco control program. Randomized trials have demonstrated that Quitline calls and a follow-up telephone coach can lead to more quitting success. And the combination of quitlines, pharmaceutical aids, and physician monitoring can help behavioral smokers to quit. In addition, quitlines let users seek consultation anonymously, which we believe plays a vital role in encouraging adolescents to disclose their smoking habits. This conference has invited several distinguished international experts to share their expertise and findings. These experts came from Switzerland, Thailand, Hong Kong, and Taiwan, who have profound experience and insights into using quitline to help youth quit smoking. The 2022 Quitline in Smoking Cessation for Youth Online International Conference, I believe, will reward every participant today with a deeper and better understanding of theories and practices of applying quitlines for smoking cessation among youth. I would like to welcome you again and wish you a successful conference. Thank you very much.
Thank you, Dr. Wei. So the next, I would like to invite Dr. Chen Mu Kwan, the Superintendent of Changhua Christian Hospital, also the conference organizer. So to give his opening remarks, Dr. Chen, please.
The Director of Health Promotion Administration, Dr. Wu, dear distinguished guests, speakers, moderators, ladies and gentlemen. Welcome to the year 2022 Quitline in Smoking Cessation Online International Conference. I am Dr. Chen, the Superintendent of Changhua Quitline Hospital. Taiwan Smoking Quitline was founded by Health Promotion Administration in year 2003 and has now been undertaken by Changhua Quitline Hospital. We have trained professionals who majors in psychological consulting, social work, and education, providing consulting services, information, and plans for people who want to quit smoking. Our success rate of smoking cessation is nearly 40%, which is similar to other developed countries with advanced healthcare. Changhua Quitline Hospital is a medical center with 8 branch hospitals, one of the largest medical centers in Taiwan. Our mission is to facilitate people's health and treat diseases. Many diseases are related to exposure to hazardous substances. From the point of view of disease prevention, we hope to reduce the harm of conditions by helping people stay away from hazardous substances as soon as possible and maintain a healthy lifestyle. To people who would like to quit smoking, the service Smoking Quitline is just a choice of guidelines for a healthy life. In recent years, the problem of youth smoking has received attention. The sooner they start smoking, the greater the dependence on nicotine in the future. In addition, currently approved smoking cessation drugs are only suitable and allowed for adults over the age of 18. Therefore, smoking cessation education consulting is the best way for young people to quit smoking. Considering that young people are more accustomed to using online communication services, and the Taiwan Smoking Quitline is not only personalized and highly confidential, but also free of charge, I believe that if the Taiwan Smoking Quitline reaches its full potential, it will greatly improve the smoking cessation rate of young people. To fully utilize Quitline to help young group quit smoking, Changhua Quitline Hospital is hosting today's conference and has invited specialists from Switzerland, Thailand, Hong Kong, and the Changhua Quitline Hospital to share Quitline's experiences and the best practices in smoking cessation. We hope to improve the efficiency and impact of Quitline for young smokers. Lastly, I would like to show my big thanks for all of you for your coming. I would like to express my sincere gratitude and appreciation to all honorary speakers, distinguished guests, and participants. I wish the conference great success, and may God bless you all.
Thank you, Dr. Chen. So before we start the conference, I would like to invite all of our speakers and participants. If you have a video camera, please turn on your video camera. So let's take a group photo together. Okay, so please turn on your camera. Yeah, that's good. And so look at the camera and smile. 1, 2, 3.
请他再一次，不好意思。
Yeah, one more. Yeah,
Oh.
Dr. Wei. You turn on your camera. Okay, once again. 1, 2, 3. Cheese. Good. Okay.
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 Thank you.
So thank you very much. So we are going to move to our conference. Today we proceed the all of the conference in English, but we have simulators translation. So if you would like to listen the Chinese, you can choose the Chinese channel. If you would like to listen the English, you can choose the English channel. And if you join from the YouTube, you also can choose the English channel or Chinese channel. And if you want to apply the continuing education credit, you have to follow the regulation to sign in and sign out. Here I use 我用中文说一次哦，就是我们今天是全程都是英文哦，所以如果你要听中文哈，在你如果是加入 Webex 的话，它这里有个地球，你可以选中文，然后你就可以听到我们中文老师的翻译。OK， 那你如果是从 YouTube 听的话，你可以选中文频道或者是英文频道。OK， 有任何问题，你可以在我们的对话方块里面提出来，有人会回答你。好 ，OK， so now we will start the conference. Okay, so the first session, that's our great honor to invite two speakers, Ms. Susan and Dr. Oliver Bilk from Sweden to share their experience. But currently, Dr. Bilk is trying to log in. So we have to waiting for him. Then we will invite Susan to start his session, in the second part session. Susan Kolek is the chair of the Global Network for Tobacco-Free Healthcare Services, an independent international and non-profit association with the main goal of establishing a common strategy for health service in tobacco prevention and smoking cessation worldwide. Today, both of them will share the same topic and separate for two parts. So for Susan, she will be going to the second part. So the topic is what is the spatial about the nicotine addiction in adolescents? How can we use the knowledge for effectiveness in quitline smoking cessation for youth? They will have the best practice example from zero to the practice. So Susan, you have 15 minutes. So if you are ready, then you can start to share your PowerPoint. Then you can start your second part.
Yes. So thank you very much for invitation in this wonderful conference. And our title from the presentation is What is Special About Nicotine Addiction in Adolescents and How Can We Use the Knowledge for Effectiveness in Quitline Smoking Cessation for Youth? Best Practice Example from Theory and Practice. And thank you, Nina. You talk a little bit about our persons from Oliver Bilke and me. Oliver is the chief doctor from the Lucerne Children Hospital for Psychiatric. And my person, I'm the chair from the Global Network for Tobacco-Free Healthcare Services. And I will bring greetings from our global network. We had yesterday a wonderful GNTH international conference with best practice from our Gold Forum member. And I know, and I'm thinking we have in this conference also people and persons from the healthcare services from the Global Network for Tobacco-Free Healthcare Services and also Gold Forum member. And it's my pleasure to share with healthcare services and practice and doctors in Taiwan, my experience from Oliver and me. This is a title from the part from Oliver Bilke, What is Special About Nicotine Addiction. I think it's important that we have our knowledge when we go in practical things with the adolescents people or every smoker in our work. And I will little bit more share quick the slides from Oliver, then perhaps he is coming and so that he could talk about the slides from him. So I will start with my part on this presentation. And my second part is how can we use the knowledge for effectiveness on quitline smoking cessation for youth, best practice examples from theory and practice. And what I say before, I think it's important that we have studies about the addiction from youth people, that we could share our knowledge. What is the special thing of youth people in nicotine addiction? And you know, we have a lot of studies from the past and also, I think, in the future about round tobacco addiction from the youth smokers. And I will start a little bit with a few in studies what I found for this. I found in an Access report that the tobacco addiction develops very rapidly among adolescent smokers. The half of adolescent smokers report a loss of control over tobacco use when they smoke 7 cigarettes a month. Half of those who have the ICD-10 meet the dependency criterion, those who, if they smoke 1 or 2 cigarettes a month, consumes. And the average time interval between regular consumption of cigarette and nicotine addiction diagnosis among young smokers estimated 1.5 years. And 1 in 3 adolescent smokers will develop 1 clinically relevant dependence up to the age, and this therefore are known health risks associated with tobacco use stand. And we found also other study, a study look what is the willingness of adolescents to participate in the smoking cessation program using a mobile phone. And this was a study from the German part of Europe. And it's very interesting in this study if the program information happened in large groups and early in the morning. I think it's also a good point when you think on youth smokers and adolescent smokers that are willing to go in the smoking cessation programs more in the early morning. As reasons against participation, young smokers maintained lack of fun, interest in time, and according to them, attractive intervents would raise the likelihood of participations. And the conclusions from this was the future cessation programs for young smokers via the mobile phone should particularly pay attention to participants' motivations to change, to hedonistic programs, components, and to attractive incentives. Programs information should occur in large groups and early in the morning to enhance participations. I think it's good we know this also from the theoretical background. And then we found also another study from the University of Zurich. Can text message make you change? This was a mobile phone-based interventions for tobacco and alcohol use reduction in adolescents. And what was here the methods? The mobile phone-based early interventions seem promising as means to address tobacco problematic alcohol use in adolescents. Often it is also to both. It's also when the smoker is older. You have often the problems that they need cigarettes and they need also alcohols. And they are appealing to adolescents, demonstrate small but significant preventive effects and are implemented at relatively low costs. And behind questions regarding their effectiveness, little is known about how adolescents engage with these interventions and which adolescents might benefit most from them. And the message was also the 3 engagement rates were upside in adolescents participating in a mobile phone-based smoking cessation program: stable engagement, decreasing engagement, and stable non-engagement. And adolescents who were younger, had no immigrant background, perceived more benefits of quitting smoking and reported binge drinking, preceding the baseline assessment, were more likely to exhibit stable engagement. The main conclusion of this thesis are that mobile phone-based early interventions can be effective at preventing problematic substance use of tobacco and alcohol. However, further efforts should be undertaken to optimize programs for lower educated adolescents who consume only one substance. I think it's good that we have such theoretical background around these things. So I talk my position in Switzerland is also I'm the president from our Global Network for Tobacco-Free Healthcare Services Network in Switzerland. I'm the president from our national network. And in my country, in Switzerland, the tobacco use by young people in the age you see from 1994 to 1988, it's lower, but we have also young people who go to smoking. You know, we have a lot of tobacco marketing in Switzerland, and this is, I think, a big problem also here. What is a focus on the approach in our adolescents working with the people? We have a prevent entry, we have a structured behavior level with the incentive system from setting, with the individual behavior level, encouragement life skills, and also smoking cessation support with environment, young people always on media, use peer, and also the message, no, I won't stop, not tomorrow. In Switzerland, we have digital programs and also we have telephone programs. You see here digital and also on face-to-face and live programs. You see here Sag Stark is a strong smoke-free plus the apprenticeship incentive system. And we have Ready for Life. This is a coaching app for individualized coaching with chatbot app to promote skills. And we have Feel Okay. This is a smoking cessation program from Feel Okay Stop Tobacco for young people for step-to-step go smoking. You see here a little bit more on the picture. You see here Sag Stark is agreement refined from tobacco products and e-products at work and during leisure time from the start of the contract to the end of the apprenticeship. Contract complies with and the reward, and contract not comply with is a resolution of agreement. Then we have Ready Life. Ready for Life is a coaching app for youth people. I think the apps and digital things and innovative digital programs, apps, etc., it's more and more also in the future for young people. The coaching app for promotion of life skills, dealing with addictive substance and vocational schools. And we have Ready for Life is also, here's a coaching app. You see the app from the website. And our Stop Smoking Swiss Quitline. I think this is our Stopping Smoking Swiss Quitline for all. This number from our Smoking Swiss Quitline is printed on every cigarette package. And the number of calls to the smoke line roster have results. All people have this number of the package. And the number is for all classes, from social classes, from all the age, from all, what do you have for smokers in our country? Also for young people, employees, students, and seniors. And this calling number had a program for individual approach. I think this is important that we talk about in Switzerland more and more for individual approach for the smoker. And so is also the program. And when the smoker, the young smoker, the other smoker go in contact with the telephone number and say, oh, I will stop in the next 3 weeks, then they become a continually Quitline support. All the support is free in calling. And I talked before, it's very individual. And I think this is also important that we look of our young people and adolescent people as a group from individual approach with our therapeutical background. I will give the take-home message from end of our presentation.
So thank you for Susan and for her sharing about like the Switzerland and Europe of the experiences. Then we will move to our next part. So our next speaker is from Thailand, and it's also a great honor to invite Dr. Chitana to share Thai experience. Dr. Chitana Unihan is an associate professor of nursing at Chulalongkorn University Faculty of Nursing. So she is the director of Thai National Quitline. Her teaching and clinical experience is psychiatry, mental health nursing, which include alcohol, drugs, tobacco dependence, and tobacco dependence treatment. So her topic today is the role and effectiveness of quinine in smoking cessation for youth. The experiences sharing from Thailand National Quitline. Professor Chitana, the floor is yours, please.
Thank you very much for inviting me to share my experience, and I'm looking forward, and I already learned from Susan, and I'm looking forward to learn about Quitline in Taiwan and in Hong Kong. In Thailand, I will go over in this session. So Nina, if I pass by, if I still have almost over the time, please remind me, okay? Yeah. Let's see. So I will try to focus on let the audience know about Thailand National Tobacco Control System at a glance, and also about Thailand National Quitline, then go to the role and effectiveness of Thailand National Quitline in smoking cessation for youth. This is Thailand, a small country of the population of 66 million, and life expectancy is 75 years. As far as our focus on smoking prevalence among Thai, you can see that in the last 2 decades, the smoking prevalence among Thai age 15 and over are decreasing, but the alarm number, this is not satisfying. The number of regular smokers last year is 9.9 million. That's a whole lot. We need to do something. Well, the prevalence scale of statistics are similar in all age group and in by gender. But if you focus on the female, the reducing rate is rather slow in female. And this will be true in the youngers, which I will focus more. I told you that last year we have total number of smokers to 9.9 million, but the number of youth, well, this is a statistic that we use age 15 to 24 years is 1.1 million. So that's still alarming. But if we reduce to only youth 19 years and younger, it's 893,000. But similar to what we have learned from Switzerland, that the prevalence of e-cigarettes, it's alarming, increasing. Okay, we will talk more about that. This is another statistics that can see that the smoking prevalence differentiate by age. And this is the number. You can see that the number of smokers in other age group is rather reduced, but not youth, but not the people age 20 and young, 20 years and younger. This may be because the year of first smoking is reducing, which means the people or the younger start smoking at an early age. That's the problem that we need to do it. Talking about tobacco consumption, in my country, it's different from others. We still have the problem of roll your own cigarettes. So in Bangkok, we compare manufactured cigarettes consumer and roll your own. You can see that the proportion, but many of them are dual users, and the same thing as cigarettes and e-cigarettes, they are dual user. Thinking about type of tobacco consumption and the smoking heaviness, you can see that the roll-your-own seems to be more heavier smokers than others. But that's something that we need to do it. Considering the quit attempt, we can see that the quit attempt in last 10 years, about half, when we ask smokers, and this is regular smoker, current smokers, are you ready to quit or do you want to quit? Only half of them say that they want to quit. But among half, never try more than ready to try. But attempt to quit is a little lower. And that's the work of all of us to make it, to make the number of ready to quit higher. Now the average abstinence rate, and this is the continuous abstinence rate before relapse. And this is, you can see that the 6 months to 1 year is quite slower among current smoker in Thai statistic. And experience and guided by FCTC, World Health Organization, FCTC. In Thailand, we have national control, national 5-year plan to lower tobacco consumption. And we have 6 strategies. Of course, one of the important strategy is assistance for those who want to quit smoking. Within this plan, the aim of the plan is moving towards sustainable tobacco-free Thailand. The goal is reduce tobacco use prevalence and, of course, protect health of Thai people from tobacco harm. You can see that we put the aim for our challenge in the next 5 years, reduce smoking prevalence from 16.4 to 14. That's a big job of us. Now, the measures, similar to what it has been said in Article 14 in FCTC, formulate and implement national policy to help people quit tobacco use. And this is the work for all parties, GO and NGO. Focus on assistance for those who want to quit. There are 3 measures. This is important measure. The first one is empower community and strengthening smoking cessation networks. Capacity building health personnel and healthcare provider in assisting smokers to quit, and capacity building tobacco cessation system and national Quitline. In Thailand, we develop, this is as a policy, the existing system, the existing network system is this. For all smokers, many of them are smokers in the community who did not have health problems. For those who have health problems, come to the hospital, and in the hospital and medical center, we provide screening, brief counseling in all clinics, and receive pharmacotherapy and counseling, including complementary supports. For those who are not, don't have health problems, or they have problems. In our country, we have 3 levels: tertiary medical center, and community hospitals. Within the community, we have village health volunteer, community leaders, school teachers, industrial or academic or local authorities. We empower them to do the screening and brief counseling, and later refer the smoker for counseling. And this for counseling at Quitline. So this is National Quitline. We are strengthening this National Quitline as a national authority, the only one Quitline in the country. So the smokers screening or have counseling and then refer to us for follow-up. The similar activity from the community, and this is the primary health care, refer to us for counseling and follow-up. and the same thing as the smoker within the health problems. Within Thailand, we are working on, right now we are dependent on U-refer system, and I will tell you later why we need this system. In Thailand, we have, let's see, okay. This is the work of, sorry. This is the work of NGO, Thai Health Professional Alliance for Tobacco-Free Thailand. National Quitline is one of the group. We help develop countrywide coverage tobacco cessation clinic. At this time, 300 registered cover all province. These do not include the smoking cessation clinic within the mental health system and in other medical centers. So this is the clinic that work with us in the past framework that I mentioned to you. Okay, so this is the work that we work together. Let's see. So come to Thailand National Quitline at a grant. I will tell you about our Quitline. This is our center. We are on the 2th floor of the Nurses Association of Thailand, and that's our webpage. Okay. We have established under the Thai Wellbeing Foundation, Ministry of Support, Public Health, National Health Security Office, and Thai Health Promotion Foundation. Start September 2008 and began its operation in 2009, approved by the National Control Board as Thailand National Quitline 3 years later, and 4 years later, we received a toll-free scheme. When we first established, we negotiate for 3 bahts per call. It's about 2.5 Taiwan dollars, but now it's all free. We have been developed our national Quitline until we have been approved by the National Health Security Office as the qualifying preventive measure under the Universal Coverage Health Insurance, in which is mean that Thailand National Quitline Service as a service provider are entitled for National Health Security Office funding system. So from now on, we are funding by two funders, which help us to develop more. Focus more on Quitline. In Thailand, for the special telephone number, we have 4-digit, 1600. This is free service for all Thai. The service hour is 24 hours, every day, no holidays. From 9 to 20 is we provide reactive, proactive, and all other services. I will tell you later. And from 8 p.m. to 11 p.m., we have reactive service only. And after that is voice record and callback service within 24 hours or by request. This is our promotion. We provide the evidence that if you quit without support, you are entitled to be success only 3.5, 3 or 5%. But the percentage of success quit, which is continuous quit, is increased to 32 by using the service of Quitline, a free call. So this is our promotion. Just refer your name and phone number by U-refer mobile application. Just use this QR code and send the name and phone number and the time that they want us to call back. And we call this a proactive call. So this is key successing factor. We thought that 5 successing factor depends on experienced, well-trained health professional. Our counselors are primarily registered nurse, psychology, clinical psychology, and social workers. Evidence-based, theory-based clinical practice guidelines focus on those strategy. And we have updated and advanced technology. We have our own database system and efficient call center. Under the quality monitoring for improvement system and outcome-based or research-based management. And I will mention to you later how we work on this. And we are lucky to have adequate resources, funding, and technical support. This is the framework, counseling framework. We use stage and process of change. And then if compared to 5 A's of other profession, if you want to look at it, for those who are pre-contem or at the contemplation period, we provide brief counseling aiming to motivate, motivation to quit. And for those who are ready, we will provide them the intensive counseling for 20 minutes to increase the confidence to quit and setting the quit date. After that, we provide the maintain relapse prevention to maintain quitting. This is our Quitline counseling strategy. This is, we say that you can quit by your own, but the success rate is very low. If you quit with us, there are three curative factors: intention, or readiness to quit, confidence to quit, and quit with help. This is at the starting point when we develop the Quitline, and then we have confirmed by other researchers that I will tell you later. This is the flow chart. All the call-in will receive by call counselors doing the screening, whether it's proxy or other interest individual, and provide the care, provide the counseling, short counseling. And for those who are intent to treat, they will be referred to quit counselors for counseling. And noticeably that proactive call or callback service will be done by quit counselors. And this is experienced counselors that we undergo our curriculum, quit curriculum. So this is in-depth. After provide in-depth counseling and set the quit date, we ask for the agreement for future service. And then we provide 6 proactive support call after quit date, okay? Now, this is the performance yearly. You can notice that we are able to help the provide the counseling, both reactive and proactive, and interactive short messages like text message, about 12,000 calls a month, okay? For those who receive interactive SMS, this is our innovation and start to increase the accessibility. Number of smokers who receive counseling service, it's about 1,000 a month, okay? And we are able to follow up at 6 months, about half or almost half, or more than 40%. For our statistic that the smokers, among all smokers who receive service, about 15% are able to quit at 6 months. But if among the smokers that receive counseling service, there will be 32%, okay? The role and effectiveness of Quitline in smoking cessation. This is the experience, and maybe the share, I don't know if it's the best practice or not, but it's something that we need to work on it. During the COVID-19, this is a challenge for us. Some of our staff got infected and social restriction policy, so the office was closed. So we are able to develop the hybrid counseling system. This is in a system that only few staff working at the center receiving and redirect the call, and counselor will provide counseling at home using mobile phone and paper documentation. At this time, the case management was employed in that the counselor will do the follow-up call by herself. So, of course, all type of service during this tough time was not as good as we expect, but we are able to offer, continue to offer smoking cessations. And this is our publication. You can Google you can search my name, and then you can see this, that the effectiveness of interactive text messages and the Quitline and the counseling, you can see that the counseling has more effective than the SMS. But thinking about the autonomous sending the text message to all mobile phone, particularly for those in the rural area, because for the youth and for people in the urban area, they use smartphone. But for text, we can go to the earlier model of the phone. So this is one thing that worked well in my country. We also provide live chat. We use application Line and live chat. This is good and common among youth. We also, I'm talking about interactive SMS only, and this is the Facebook story that are in Thai. We provided for route for accessibility and sharing the information. This is YouRefer. It's the mobile application using by anyone, can be anyone. This is a temporary measure instead of medical e-referral system as is existing in some developed country like Australia or in America, in that if you go to the hospital and in the hospital, they have the system, medical record system, and then they can click and refer from the hospital to Quitline and vice versa. If the client get into the Quitline, we can refer back to get the pharmacological treatment or other treatment with the medical doctors. But right now, medical e-referral has not been exist. So we use mobile phone application. We call it YouRefer, okay? To get into the YouRefer system and learn about it, okay. You can get to YouRefer in many places by the QR code or get into the World Wide Web, our World Wide Web. Now come to the focus on Quitline for youth. I hope that I have some time left, okay? For Quitline for youth, in Thailand, we provide, we are national Quitline. So we provide service for all ages, including youth. And since youth start to smoke at younger age, so the number of youth, this is in the global youth survey. You can see that the e-cigarettes among Thai school age, this is similar to other countries that the number of e-cigarette use is increased more and more, okay? This is global youth survey, and this is the survey among Thai National Statistics Office survey, still similar patterns that the youth are smoking preference are a little high, and the preference of e-cigarettes is this, okay? Now, come to clients who use Quitline. For all clients, about 10,000 clients who receive counseling, about 11%, not more than 15%, are youth, which is under 20 years. These are school age. But we have another measure to help new smokers who are age 11 to 12 to 24 years and smoking less than 1 year. We believe, and the document it says that for those who are new smokers, success more than the one who are using or smoke cigarettes for more than 1 year, okay? And this is YouRefer. You can see that the only few youth has been referred for Quitline service, which means it's our challenge for us to outreach to the youth. And of course, we need to work with school, teacher, and in the community more than in the hospital, because for those smokers that come to the hospital all have health problems, but many youths are not. So this is our challenge, to work with our network and ask them to do empower them to do some screening and advice, refer to us for Quitline. Okay, we don't have a specific measure for smoking cessation for youth, but because we conduct research and many all activity, we do the knowledge management. Our challenge is the development of smoking cessation service and the system innovation will do and increasing service accessibility, particularly for Thai youth, by monitoring the service. We did not have CPG tailored for the youth, but continue to update relevant parts to fit specific group, include youth. As I told you that we have the problem of COVID-19, our CPG are tailored to fit the clients who are called because of infected, COVID-19 infected, or after the COVID-19 infected. So we are do the tailoring by the work of all staff, because we determine to be a learning organization. So all staff need to work together in updating the CPG, including e-cigarettes. But the e-cigarettes, we don't have enough findings on Thai people. So we are doing the research, and this is I'm not able to share the research about e-cigarettes, but the other research. Okay, this is the one. We do the predicting factor of quit smoking among smokers who call Thailand National Quitline. This is the clients of all ages. So three factors is confidence to quit, number of follow-up call or support call, and quality of life mental components. So these are the things that tell us how to focus in the counseling. So all clients, we focus on increased confidence to quit before setting the quit date. And we are maintain all effort to do the follow-up and support call. During the counseling, we are concerned about quality of life and what will happen in the mental components, which we focus that smoking, not only nicotine dependence, but emotional dependence and social dependence. So this is one thing that help us to work more. And this is for those who interest in statistics of that research. This is the research talking about Thai adolescents. So we found out that highest impact factor influence the quit attempt was nicotine independence, time spent with peer smokers, and self-efficacy to resist smoking. So the common predictor is self-efficacy to resist smoking or self-confidence. But the new one pertaining Thai adolescents is nicotine dependence and time spent with peer smokers. So I mentioned to you that this one, for this research, we focus on emotional concern of lifestyle among all users. And this is the user at all age. But for adolescents, we focus on time spent with peer smokers, okay? So this is for those who are interested in the statistics. So this is what we are updating using the research results and focus on client-centered counseling technique. Focus on assist youth with high level of nicotine dependence toward decision-making to quit. Working on practical lifestyle change during socialization with peers related to mental components. You know that the youth is really scaring about their self-image. And we have interesting result that people at all age among Thai, they are afraid of the breath smell, and they want to quit because they have a bad breath. And this is related to mental components and lifestyle change, okay? More and more emphasis must be improved self-efficacy to resist smoking or self-confidence in quit smoking. And of course, we put all the effort to deliver the follow-up calls and giving additional support and maintain quitting. So this is our lesson learned. The brief intervention to include motivation to quit is important, particularly for those who have nicotine dependence. So if you are teachers in schools, you have to work on searching or screening for smokers and identifying reason to quit and level of nicotine dependence. And this will increase motivation to quit. And let the professional counselors work on self-efficacy to resist smoking. So this is what the school teacher and the community leaders can help together with the counselors. Self-motivation and coping skill. This is daily life, or what you can call a lifestyle change. Motivation strategy, reducing ambivalence to change by supporting them, and address social influence that affect smoking behaviors. So more and more research need to learn about this. So more message is, in the the time of increasing e-cigarettes, we need to do more research on e-cigarette user, and it's in process. But smoker at young youth or young adult start using e-cigarette, believe that it will help to quit other tobacco products and following peer groups. This is excerpt from counseling experience. And for many of them call Quitline because they notice that health change, this is among e-cigarette users, the health change is changing, it's observable. Okay, so they call and want to quit. The quit attempt or quit rate among dual user and non-e-cigarette user were not noticeable among the counseling service. And this is our conclusion and the challenge. TNQ, or Thailand National Quitline, continue to improve smoking cessation for youth by providing counseling based on tailored CPG to fit youth callers. I don't know, maybe in the near future we will have special CPG for youth. Our challenge is increasing reach or service accessibility for Thai, particularly youth, because they are waiting for us to help them. And more important is, we are develop research and development innovation, the integrated smoking cessation intervention in the primary care service system. If you Google and search under my name, you will see these publications to improve and empower the village health volunteer or other community leaders who are work very close, and these including proxy who call Quitline. So we may develop the CPG to offer the counseling to counsel the proxy to help their youth, to help the youth to do the quitting. So the challenge, this is the challenge that I already tell you, and this is at the time that is available. Sorry for bring it over time. Thank you for all of your attentions, and I'm ready for question and answers. Thank you.
Thank you, Professor Junata. Very excellent presentation. Our Q&A session will be after all of the speakers. So we will move on to our next speaker. The next speaker is from Hong Kong. So it's also a great pleasure to invite Dr. Kelvin Wang, the Associate Professor at the School of Nursing at the University of Hong Kong. So Dr. Wang is the leader of Smoking Cessation and Tobacco Control Team of Hong Kong University, and also the council member of Hong Kong Council on Smoking and Health. So his research focuses on behavior intervention, addiction policy evaluation, and health communication. His team's community-based smoking cessation program has been awarded the American Academy of Nursing Edge Runner as an excellent nursing model. So today, Dr. Wang will share a proactive cessation service model integrating research and policy advocacy. Hong Kong University use Quitline. Kevin, Professor Kevin, the floor is yours.
Thank you so much. Thank you, Nina. I hope you can hear me. So thank you for your very kind introductions. First of all, can you allow me to share the PowerPoint?
Yeah.
Thank you so much. It's really my great pleasure and honor to join this international conference to share some of the experience in Hong Kong. So I really grateful that I also learned a lot from the Taiwan's preference and also the e-cigarette, increasing use in the youth, and also very grateful to learn from the Susan about the experience in Switzerland and also the Gentana, which I think we share a lot of same factors affecting the youth smoking. So. Sorry, PowerPoint. I'm sorry, my PowerPoint just missed. Okay. Okay. So yeah, to start with, I'm not sure whether you can see the next slide, but I just assume you can. So all this project within the Quitline has been funded by many different fundings, including the government fundings, cost small project fund from the university, and also from the some professorship funding. So to start with, as we know that most of the adolescents, actually most of them or near of them has started smoking in the early adolescence. Only few of the smoker actually they start in their late adulthood. So near 97% of the smokers starts smoking before age of 30. And also in Hong Kong, near 62% of the Hong Kong smokers smoke before age of 19. So this is quite similar worldwide. So starting smoking in the early life actually was associated with greater difficulties in quitting, and also of course increase the higher risk for the premature death in the future. As we know that one out of two smokers will die prematurely, but if the smoker start to smoke so the U.S. Surgeon General actually has all summarized all those damage of the smoking in the youth, a very comprehensive harms to the health. And adolescents' brain is particularly important because this is a very sensitive period, their brain development. So smoking will affect the behavior and also some neural alternations. So the preference of the smoking in Hong Kong, which I think is quite similar to the Taiwan, as reported by Dr. Wu, that the current cigarette consumption, conventional cigarette consumption has been reduced from 9.6% in early 2000 to up to now around 1.2%. Last year. So that is really a dramatical decrease. This is mainly due to subsequent, many different tobacco control policy has been implemented in Hong Kong, as you can see that in this, blue dot line. For example, in the early 2000s, we have the total ban on the smoking in the public indoor area. That has been successfully reduced the smoking from 9.5% to around 6.9%. And then there was subsequently 2 times of the tax increase, 50% and also 42%. This further reduced the smoking preference to around 3.2%. And this also has some effect in the recent year to 1.2%, including the recent years increasing the cigarette pack warning size to from half to 85% of the pictorial warning in the cigarette package. Same as Taiwan, we are worrying about the increase in the alternative tobacco use in youth. So in this graph in your left side, you can see that the preference of the e-cigarette use is a little bit high. 7.7% of ever use and 1.1 for the current use, which I think is quite comparable to the conventional cigarette preference. But don't forget, this is only a very short time period for this increase. For the preference of heated tobacco product, that means mostly what the heat-not-burnt product of IQOS. So you can see that the current use is around 0.5% in 2018 to 19. But reduce a little bit to 2020 to 2021, 0.3%. But that will become more preference if we do not ban it. So there are several challenges about the youth smoking, which is quite different from the adults. I think both Susan and Gentana has report already, but I just here to add a little bit more. So in this graph, you can see that the researcher report that the smoking cigarette per day, you can see that it's really fluctuating between each week and also between each day. So that is kind of the difficulty you provide the consistent intervention for the youth, because their addictive level or their smoking pattern are quite fluctuating. So also the predictor for the successful quit in the youth and the adult are a little bit different. In the adult, mainly it is because of the nicotine dependence. But for the youth, it's more diverse, including many will be the psychosocial processing or the mental health issue, as also reported by Gentana. So general smoking cessation services could hardly reach these youth smokers, because most of them are not proactive to seek help. So more proactive services are needed. There also are some barrier, very obviously, for youth smoker to seek help to quit smoking. Many consider themselves as smoker, but few consider themselves as addicted. And quitting is not viewed as an immediate priority, even when they are interested in quitting. So seeking help is conflicting with their personal value of youth. They are most likely put the importance on the independency, autonomy, self-image, or the self-identity. So it is kind of the contraindicating for themselves to seek help for the youth quitline. And also being seen to seek help is viewed by embarrassing and a sign of the weakness as perceived by the youth smokers. So that is making all the smoking cessation services very challenging. So another barrier for the youth to seek help from the smoking is that the privacy and confidentiality concerns. Underage smoking actually is kind of the perceived punishable behavior, particularly in the Chinese culture. So the fear of revealing their smoking behavior to their parent, teacher, and also important others. Also, they will be reluctant to share their experience with a stranger because the youth quitline counselor or the advisor probably will be perceived by them as a stranger. So also they are very doubts about the effectiveness of the services because they were saying that the generic cessation services will only developed or feasible or effective for the adults or the older adults because these older adults are more addicted, so they need the services, and they perceive themselves not that addictive, so they don't need to seek the services from the youth quitline. So all this misperception about the effectiveness and safety of the cessation treatment will be kind of the very important barrier for them to seek the services. So how to minimize these barriers and then provide more active and effective services? First of all, is to provide the youth-focused smoking cessation services to create and maintain branding that appeal to the youth. That means you need to be stylish, trendy, eye-catching, fit to the youth, style. Highly accessible by the multiple means. So in the old days, we are mostly rely on the telephone, but nowadays we cannot just rely on the traditional mobile phone. we need to use various methods, for example, the social medias. And face-to-face contact nowadays is not necessary at all for the youth. And second is we need to really ensure the privacy and confidentiality and to give them the confidence that all these services or the content are highly confidential. And, the parental consent should not be sought because they definitely don't want their parents to know they are smoking. And also need to respect the youth autonomy, youth center services, and also need to create the absence or the pressure from the professional or the counselors in order to make them, kind of the user-friendly. So with all this principle and all those knowledge, we create our Hong Kong U Quitline, which has been established in 2005. So this is the first smoking cessation services targeting youth smoker age under 25 years old. And the special feature is that we provide the peer-led telephone counseling with the multiple follow-up. So those counselors, those advisors actually are the youth also, and mostly will be from the health background, like nursing students or nursing graduates. And so we help the services goal is to publicize quitting among youth smokers and also to encourage, support those who want to quit by providing advice, counseling through telephone. So our center has been recognized as kind of the core partner for the WHO Collaborating Center for Smoking Cessation and Treatment of the Tobacco Dependence since 2012. So actually we did a lot on this Quitline services. We train a lot of so-called the peer counselors. So since 2005, we provided more than 14 training workshops, and this has been totally include more than 700 peer counselors. So we also, evaluate in a rigorous way. You can see that below is a paper published in the Journal Adolescent Health. We found that after the training, all those peer counselors actually has been improved in terms of their attitude, knowledge, perceived effectiveness, and also perceived importance. So as I said, that we actually quite put emphasis on the proactive services. So we do a lot of so-called the proactive outreaching recruitment. So first, we actually not sitting there for wait a call. We go to the community, and particularly those very, so-called smoking hotspots to recruit the youth smoker. So in this graph, you can see that actually they are smoking around the rubbish bin. So we actually, our counselor approach them in this area to recruit them for the services. And of course, we also liaise or receive the referral from the schools, from the vocational school and different institutions in Hong Kong. And also we design the referral form for the school NGOs and referral by the family, friends, and also they can have their self-referral. So in recent years, we are very eager and proactive in develop the online method. So we have created a website, which is quite attractive, I think. And also we have created a lot of different social media like WhatsApp, Facebook, Instagram, and to recruit and also to directly provide the services through those platforms. So these are the social media website we have created. So since the 2021 March, Hong Kong U Quitline has been strengthened to access and reach through the Facebook and also Instagram. So the user or the youth smoker, actually they can do some self-assessment about the nicotine dependency level, their mental health issues, or their other lifestyle behavior through some self-assessment questionnaire in this social media. And after that, and they will provide some advice and then ask them whether they are interested to join the services to quit the smoking. So you can see that these are all the posts, provided in the social media, and they are very creative. Actually, these are all the posts designed, and modified and provided by the youth in Hong Kong U. So they are very attractive to the youth smokers. And we actually has targeting, for example, some very important festival attractive to the youth smokers. And also we capture very trendy topic, like in recent day, there will be very interested to know more about the water pipe, shisha, and then we try to explain to them that is very harmful. Again. And also we design a lot of different leaflet here, just show you two of the latest leaflet for promoting our youth Quitline program. So it is kind of fit to the youth preference. So overall, the services has received more than 16,000 incoming calls, and we successfully provided counseling for more than 3,200 smokers. So the overall quit rate at 6 months is around 24%, and also 16% of those who have not quit but successfully reduced at least half of the cigarette consumptions. This is the table trying to summarize the characteristic of all those smokers starting from 2015 to last year. So you can see that most of the youth smoker actually they have the mild to moderate addictive level, and also only a little proportion, 15%, the heavy smokers. And there's around 25 or 24% have not previous quit attempt. 3 of 4 actually has the quit attempt before. And also there's about 23% has not very immediate intention to quit, and also many of them actually has rates their health as good, which apparently is not that correct because they have the smoking. And then as Gintana also point out, the mental health actually is concern or the issue in the youth smokers. So you can see that around 40% of the Hong Kong youth Quitline caller, they actually has the depressive symptoms as categorized by the CSD questionnaire. So when we try to understand the reasons want to quit and the difficult to quit, most of them will say that the reason why they would like to quit is to maintain healthy, save money, and for others, for example, family, friends, because they already have illnesses or the health problems, and also someone asked them to quit. And for the common reasons of the difficulty to quit, mostly will said that people around them are smokers. That means they have a lot of the smoking peers, and then it's the nicotine withdrawal symptoms, craving, peer pressure. Smoking become a habit, feeling very stressful. They need the cigarette to help them to relieve their stress, depressed. And then I will also talk a little bit on the research finding using this youth Quitline, because as a research university, actually we put a lot of emphasis on the research on the youth smokers. So first of all is the services evaluations. So in the very beginning, we actually has tried to evaluate the services and found it to be quite effective and published this paper, these 2 papers, and a recent paper published in Journal of Adolescent Health. So another area is try to understand more about the determinants of the youth smokers. So we find that there are some factors promoting sustained quitting. For example, if they have a family member recently quit smoking, that will provide the support for them. If they are more enjoying the physical health in the past months, if they have higher confidence, self-efficacy to quit, if they use some distractive method like 5Ds method to cope with the craving. So factor that will be a barrier for sustained quit, including if they have the depressive symptom, and that will be very challenging for us them to quit smoking. If they're living with a household member who also smoke, this is very apparent. If they have the perceived difficulty to quit smoking, they are less likely to sustain their quitting. As also similar to the Thailand experience, we also observed that mental health is very important factors. So we published this paper in the Decoding and Topography Research to understand the depressive symptom or also the quit attempt associations. So in this two graph, you can see that the solid line are those who do not have the depressive symptom. The dim line are that with the depression symptom. And the outcome is the quit attempt in your left-hand side, or in the right-hand side is the smoking abstinence. So you can see that if those who do not have the depressive symptom, they are more likely to have the quit attempt, and also they are more likely to have the smoking abstinence. So the mental health actually play an important part in determining whether they can be successfully quit. The second thing we find it is very interesting is the quitting trajectory. So traditionally, we only look for the point preference of the quitting. But recently, I think that is increasing attention to the whole trajectory of quitting. So we try to analyze the data, and then we can categorize three types of the trajectories. The first type is the quitters. The second type is reducer. The third type is persistent smoker. So in the right-hand side, you can see this, right? The first one is the quitter. That means when you deliver some intervention, they'll quit very quickly, right? Within several days or within 1 or 2 weeks, and then they can maintain this abstinence throughout the years. Another type is they will not quit, but they will substantially reduce their cigarette consumption numbers, but they just maintain that number. They cannot further go for the quitting. And the last type, of course, is what you have done cannot change their quitting behavior, so they maintain smokers. So the you can see that reducer actually consists biggest part. So my advice or my future research direction probably will try to identify these reducers at the very beginning, and then to target, personalize, to do some intervention for this reducer, because they are more higher chance to be success, and we deserve some of the intervention, more personal intervention to them to push them to quit. And also we found that we always focus on the smoking, but actually this adolescent, they have also some other lifestyle behavior problems. And then we start to think whether we can also intervene their other lifestyle behavior problems in order to build a holistic health for the adolescents. And this probably will also help them to quit smoking. So you can see that in the table, many of the smoker, actually, they also are the drinker, 24.2%. And many of them actually has not, reached a good level of the physical activity, 40%. And also, 40% has the unhealthy diet, and also 3.7% has drug abuse. So it is quite a message that this Quitline platform actually is also a good platform for us to run other lifestyle behavior interventions for the youth. And also it's quite a good platform for you to run some drug abuse interventions, because usually this group of people will not be easy to identify. And then is the Quitline services in Hong Kong also serve as kind of the platform for evaluate the policy. So just to put it in brief, when we have a smoke-free legislations in early 2007, then we try to monitor the services used in the Quitline, and then we see that there was a dramatic increase in the services needs after the legislation. But of course, later on, it's just died down to the normal situations. And this is very important because Hong Kong now has been, totally banned the electronic cigarettes. And this is we use the Quitline data to check whether their use of e-cigarette can help them quit. But we find that it's not quite helpful for the e-cigarettes. So this is kind of the evidence provided to the government to consider for the total ban on the electronic cigarettes. So other than research, we also think it's very important this Quitline serves as a platform for the knowledge exchange and also policy advocacy. So we are very hardworking on promoting all this Quitline evidence, figures, findings to the public by different means. Like for example, here in the newspapers, and we organize a lot of press conference to attract the media to continue to focus on the youth quitline services or the youth smoking issues. And we also develop a lot of the policy implications, report briefs to the government. For example, here, this one, we try to use the youth quitline data to advocate for the increase in tobacco tax, which is the ultimate important policy for promoting youth quitting. And recent year, we are more focusing on the tobacco products, e-cigarette or heated tobacco products. So use the Quitline data to provide the evidence and to advocate the public to lobby the legislators, and also to very actively, promote it in different medias. And finally, this has been passed and totally banned for the alternative tobacco product in Hong Kong. This year, April. So now Hong Kong cannot sell, promote, produce all these alternative tobacco products. So that's all. I would like to thank for the user for the youth Quitline of the Hong Kong U, and also the PR counselor, and also particularly important to thank for the Professor Sophia Chen and Professor T.H. Lam. I think many of you probably know Professor Chen and Professor Lam because they are involved in this field for a long years. And also particular thank for the Dr. Kevin Look for preparing this PowerPoint, and also our Hong Kong U Quitline researcher, and also of course the whole team in the School of Nursing. So thank you so much. I welcome any comments later on the Q&A session. Thank you.
Thank you so much. Thank you, Professor Wang. Very excellent experience in Hong Kong.